Now, when you look at HIV in Uganda, it is rising up among the youth because they don't have information. We took it for granted. When the medication came in, when we have the support systems, when we have this, the health care worker system, and we took it for granted that I will take the medicine. It's okay, ARVs are there, I'll swallow. But sustaining yourself onto that medication is another issue. It needs us further support. That is what we call pill burden. So somewhere, somehow, there are challenges with our healthcare system because of reduced education and information. I remember those years when the late Bishop Kauma stood up and said, there is HIV in the church. The church got up to take care of its people and spread the message. So everybody happened to take part into these challenges. And today is a different story. We are relaxing and we are saying, pressure, I'll take some pawpaw seeds and I'll be well. Do we have those centers where persons with disabilities, with HIV, with different health issues have access to a community center where she can go to check on her blood pressure, diabetes, and so on and so forth regularly? Let's take an example of myself. I go for my ARVs from a different point. I go for physiotherapy from another point. I go for massage from another point. So we cannot find a one-stop center at an accessible point in a community where many people can have access to this, to healthcare services. And also the support care systems are breaking because many of us who have been into these systems, I've seen my sister Flavia coming in here, we have been there, but we are not supported. Today we are discussing a very important system of the Ministry of Health, of the community healthcare systems. We have worked and voluntarily supported and provided services, but when it comes to any facilitation, we are not considered for that. So we are burning out. And if people who supported Maxensia to be strong, to take her medication, to stand straight, to stand amidst the challenges, are wearing away, now who will be there for these other youth, for these other people who are getting different challenges? Emma has talked about the communication. If I can ask how many people can raise their hands to tell me.
Sorry, Mrs. Nachibuka.
The sign language interpreters.
One more minute. Just one more minute.
Sorry?
I'll give you 1 more minute to conclude.
Sign language interpreters within hospitals. I've spoken to these people with disabilities who cannot speak, who cannot hear, and are getting under or overdose because they don't understand the prescriptions in the hospitals. There are challenges. The challenges are quite enormous. And Doctor, I'm happy that you are a member of Parliament. What happens to the health insurance? Where everybody could be able to access health care free of charge, because the ED said it is basically accessing health care services without too much cost. What happened to the health care insurance policy, which is in Parliament, that has not been implemented? Now, as a person who has lived with HIV for all of those years, Honorable, when we hear these laws that are pushing us away, that they will determine that I intended to transmit HIV to this person and I'll be put in prison because of the HIV law. You have mentioned a case, a scenario, before you came here, of this person, of a key population. Today we have the anti-homosexuality law. Will it pull people to come to the centers to have access to healthcare services, or it will pull them away from accessing these services? And we know these people, the key populations, the LGBTQ, have the highest percentage of HIV in this country. So the challenges are really enormous. Thank you.
Thank you very much, Mrs. Nachibuka. She makes strong pleas and advocacy, but she also appreciates government, the trajectory of the healthcare system. Ladies and gentlemen, unfortunately, our population is 70% youthful. I think there are people who did not live to feel the experience in the 80s and 90s when we were having multiple ARVs to take, about over 10 and so forth. It's been long since I have seen a patient with herpes zoster. So I think the healthcare system has been quite responsive, and I'd want to commend the leadership of the country, but the frontline healthcare workers, and most importantly, Ministry of Health. That the trajectory has been, it has been a long one, but we are seeing fruits. We are seeing people who have been living with HIV/AIDS for the last 20 or 30 years. So I think we deserve a round of applause. And to our development partners, CDC, PMI, Malaria Consortium, USAID, and so forth, we do not take the support you have given this government for granted. Please continue holding our hands. We are not yet about to let go of you. If you want land titles, stay here permanently, we'll give you those. But we do not envisage you leaving us in the middle of the ocean. And I am not on good authority to talk about the National Health Insurance Bill. It has not yet come to Parliament. It has not yet come to my committee. I think it's somewhere between Ministry of Health and State House. And good enough, I see Dr. Sare Biachika here and Dr. Laro here. At your own time, please whisper to those who need to know where the National Health Insurance Bill is and at what stage. Parliament is ready. There is buy-in. Once it comes, we'll process it within the necessary 45 days. We're more than ready. We're expecting it. So thank you very much. We'll go to our last panelist, who is Miss Rita Nampera. Rita, can we please use 5 minutes? And your question is as follows. In Uganda, all healthcare services are under the stewardship of the Ministry of Health. Please share your most challenging situation in accessing healthcare services from a non-governmental health facility. I'll underline that non-governmental, so Dr. Larry, you have a sigh of relief, not government, but a non-governmental health facility, and how you would advise the government to address such challenges. But you can please, you're still free to make cross-reference to the government facilities in your pursuit, which you think has given you the service.
Thank you. I'm called Rita Nampebwa from Chileka. Nga nze badde nsaba nkozesa Uganda. Nze mama w'omwana abasawo gwe bakuba overdose n'afa mu ddakiika 10. Gwali mwaka 2022 nagenda mu ddwaliro eryo lyennyini n'enzaala omwana nga mulamu bulungi era gye nanywera eddagala ng'omwana era bamucekengako nga mulamu bulungi. Kati jjukira baali bannongoosa bwe naddayo for review ninzirayo ne mbakubira ne mbagamba omwana ono mbadde njagala bamutayirire ku lunaku lwe naddayo for review. Ne bampa olunaku olwokubiri nti dokita wajja okubeerayo specialist. Era twakeera ne batuwa essaawa zaali 2 era twali tutuuse. Ne tusooka ne tulindamu dokita twamusookayo. Kati ne bamala ne batuyita nti bali ready. Ne batuggyako omwana ne bamutwala mu kasenge endowooza gye babatayiririra. Naye nawulira ng'omwana akaaba. Ngenda owulira ddakiika nga 5 omwana nga mpulira tekyakaaba ne ndowooza bamaliriza. Ne bampita ne baŋŋamba kwako omwana. Ne ŋŋamba dokita mumaze ne bagamba tebannaba. Naye omwana muyambaze tetugenda sobola mutayirira. Eddakiika eyo nga ndaba abasawo bavaamu mu kasenge bandekawo naye nga ndaba omwana yeesika. Ne ŋŋamba kiki omwana abadde ki? Ne ŋŋamba oba ayiseemu empu. Ne bagamba mwambaze mangu ogende. Omwana tetugenda sobola mukola ki mutayirira. Kumbe nga dokita amukube overdose y'eddagala ng'omwana yeesika neŋŋamba omwana abadde ki nga nyambaza omwana manyi mpewo yemuyiseemu kumbe eddagala omwana ali kufa kati mufo ky'okumwa kye mwali butegedde nti nno omwana bamukubye overdose oba bamutwale kubanga abasawo muba mumanyi nti wema nkoze ekintu nga kino ensobi muba mumanyi kyekiddako naye bandekera mwana nemala ddakiika ndaba omwana afa kwe kudduka okudoonya gye batwala abaana simanya munasale ngenda in that way nga nziruka ngenda olaba omwana ava omusaayi mukamwa ne mu nnyindo ng'omwana afudde kati we balaba ekyo buli musawo ng'atunula ku mwana agamba abadde ki ng'ate mu kusooka we twajja nga dokita tannajja abasawo baaliwo ate ng'ejje nalinywera ddagala mu ddwaliro eri abasawo baali bamanyi ne basitula ne ku mwana before nga dokita tannaba ne bagamba omwana abadde ki omwana gwe tusituddemu wano nga nange ngambagamba simanyi kati bamutwala bangobayo mu kasenge nga nange sitegeera mwana kyabadde nga nkozesa amaanyi ne mumagamba siva mu kasenge kano omwana muleese mulamu abadde kimugamba mutya nti afadde oba afa mumuteekako oxygen nga bangobamu nenemeramu ne baleeta ne bagezaako okuteekako omwana nti bamuteekako oxygen naye ng'omwana already afudde nafa nawunga nengwa eddalu ate baali bakamala okunnongoosa kati nga nzire eno nzire eri abasawo buli omu nadduka nga buli omu takitegeera kikibaddewo kumba omusawo yakoze ensobi n'akuba omwana overdose kubanga era twagenda ne tufuna postmortem emulago nga kiraga omwana bamukubye overdose y'eddagala naye nzize wano okuwa obujulizi n'okwebaza gavumenti bintu byange bali omusango gwange bagukolako naye simanyi nti sehad ate era nali simanyi nti waliyo ekibiina ekya sehad ekiwolereza abantu mu misango ku bwereere nali twafunako balooya kubanga twali tutambuddeko ne tugendako ne mu kooti naye ng'abeddwaliro bagulirira naye nga lumu nali ntudde ku mulimu gwange nga nkaaba nga tuva mu kooti nga bagamba tetulina bujulizi bumala kumbe nga baddwaliro bawaddeyo sente naye mba ntudde nga nkaaba nga tuva mu kooti nga mpulira n'amaanyi gampeddeko kasitoma omu omwami nandaba naŋŋamba okaabira ki ye mwami eyandagirira ku sehadi era bannange sehadi mbeebaza ne gavumenti nzize wano gyebaza okunnyamba wadde nawulira wadde banjirira obusente bwesobola gamba nti bwagula omwana wange naye kale mpulira nti omutima gwatoolokamu bannange mbabuuza woba ofiiriddwa omwana oyinza osaba sente mmeka bakuyiririre sente z'omuntu teziriyo ziyinza kumala naye badde twatuula ne tutegeeraganya ne tukkiriziganya nga mpulira sikyayagala biddamu kubanga nebaza mukama naddamu nefuna olubuto olulala oladde nafunamu damage mu kugwa kuli nga bamaze okunongoosa mu kudduka mu kulwana naye namala ne tufuna treatment nenziramu nefuna olubuto nenzaala omwana omulala kati ndati process we nali ndi olubuto kati nga mpulira sikyayagala genda biddamu naye nga batwetondera ne bamanya ensobi yaabwe naye ku lw'okuba balaba ekibiina kya sehad nga tebasobola kuba wanguzi ne bakkiriza ne tudda mu settlement ne banjirira kosa mu bumane naye bambi mwebale sehad Uganda mwebale gavumenti kati mbadde nsaba nalina mukutya nakati sinatereera baizaawe bannange mwegendereze ne ku Mande nagenze nengula silapu ya panad already ngeri expired naye nga bajinguziza bannange muba mugenze mu ddwaliro abasawo oba simanyi oba bali stressed oba si gwe mulimo gwe bakola akuba eddagala naye nga siri alina okukuba luli namubuuza omwana amazima panado ng'eri expired 2022 ng'ajinguziza ku mande kati bannange mbadde mbasaba mba mugenze mu ddwaliro buuza omusawo dokita simanyi oba kyetaagisa nze okubuuza omusawo ne mubuuza ddagala kirino lyonkuba lyaki kimujjukizaako agenda okulaba oba ng'alabako ng'akubye ensobi akoze milligrams ennyingi bannange amazima eddagala lyabadde era luweddeko neŋŋamba bannange nkoze nti kati newendaba ng'omuntu akuba omuntu mubuuza eddagala ly'opimye lyeryo bannange mpulira ndimu okutya n'okugenda mu ddwaliro kubanga kyantiisa nnyo omwana okufa mu ddakiika 10 amazima ga katonda ng'omwana anfuddeko naye sehati mwebalire nnyo ddala kati mbasaba oba gavumenti mwe mubateekako layisinsi ennyingi ey'omusolo sente basaba sente nnyingi ate nga n'abasawo bwe balina tebali profession kati mbadde nsaba
mama nja kuwayo dakika
obaani avunanyizibwa mu ekyo mubeere nga mulambula abasawo mu malwaliro waliyo abasawo abatamanyi engeri gye gali malwaliro ga private bawa sisita anti wa anti omulimu n'aba nga talina kyamanyi naye nga yakujjanjaba yakuba empiso naye olw'okuba nti eddwaliro lya anko n'afuna kyansi eyo ey'okola mu ddwaliro mugende musindikeyo abantu abakebera ab'abasawo bali no obukugu mu ekyo kye bakola.
For purposes, let's clap for her. For purposes of our donors, allow me to just wrap this up. So the lady up here took a child for an examination shortly after she had given birth, and she had taken the child for minor surgery, circumcision to be exact, and she says the child was overdosed. And the doctors panicked upon seeing that the kid was overdosed, and she was left in the room alone with the child, and she demanded to know what could have been the problem. The doctors were all panicking. They all seemed not to know what the matter was. A few minutes later, the child was bleeding through the nose and the mouth, and she was perturbed. She nearly lost her conscience at that time, but she stood the ground and she was requested to leave the room. She demanded for answers. She didn't leave the room, and later on she confirmed that she lost the child. And she later got to know that the kid was overdosed by one of the doctors, because the same hospital she had taken the child to, it's the same place she was going for her antenatal visits. Later on, Sehad came into the case, and they realized, the hospital, that they could not bribe Sehad, and she thanks Sehad so much that not a penny was requested to take up her case. She realized that a mistake was made by the hospital, was not willing to say sorry and to take up responsibility. But upon Sehad taking up the case, they later made a turnaround and apologized. But she says there is no amount of money that can be paid for a child. And she asked a question: are these doctors experts? Are they stressed at times? And she says from that moment till now, whenever she goes to the hospital, she asks very crucial but uncomfortable question: do you know what you're doing? She always asks, are you sure these are the milliliters you should give? And she's wondering, how often do government officials make rounds to check on the doctors in the different health centers? She said that most of the health centers we have, because they're owned by family members, at times the people practicing medicine there are not professionals, but they're given jobs. Her plea is to government to make rounds, and I'm grateful Dr. Olaro is here, is to make sure that capacity is given to doctors and to check. And she wonders how best we can make the license of doctors be extremely hard to get, so that we can maybe sieve the right professionals and those who are not. Thank you.
Thank you very much for the interpretation. Colleagues, these are just living experiences of that ordinary Ugandan down there in Koboko, in Kamwenge, in Ruchiga, in Moroto, Kotido, and so forth. And in the beginning, I made mention that the healthcare system is ballpark. We need to look at governance issues. Governance starts from the top. If there's no buy-in from plot one, which is State House, you know the man who lives in State House. If there's no buy-in from there, there's a trickle-down effect. The success stories we have seen in HIV is there's been buy-in at the most senior office of the country, but governments should also cascade beyond Ministry of Health to local governments. And this is where we're seeing the problem in local governments. They have one local government, just two districts apart. One is doing good stuff, the other one is doing bad things. And the DHO, does he supervise, and so forth. Sometimes we don't expect Ministry of Health to jump from the center to go in. Some of these vices are inherent to certain people. You find an ambulance driver, you find a nurse, absenteeism, and so forth. It's about self-consciousness. But nevertheless, this mantle of supervision rests on the supervisor. So please, medical workers, let's pull up our socks. Unfortunately, medical ethics in training schools is only given about 3 weeks to a month. I think it should be a standalone module that should even be examined so hard that if you fail, then you don't qualify as a doctor, because we are seeing a lot of mistakes coming in from there. And of course, there are opportunities for death audits in all these health centers. The question is, are the maternal death audits done? Are death audits done per se? And otherwise, we are seeing a lot of mistakes coming from the private sector to the government sector. A case in point is Kawempe Regional Referral Hospital. Kawempe Referral Hospital, 80 deliveries per day. Super hospital. As government, I'm embarrassed to say that their staffing is 41%, but they're giving us 80 deliveries per day. Then one baby dies and it's all over the media. And where has this baby died? The baby comes from all those quack clinics around Boise, comes with asphyxia, comes with hypothermia, will die 8 hours into admission, and it will be captured that that death occurred in Kawempe Referral Hospital. So I think we need to crack the whip. In the private sector, we need to know what they're doing. Some private sector facilities have 1,000 C-sections in a year. I think that raises red flags. Without mentioning names, why are their C-section rates higher than the average of 15%? Ladies and gentlemen, it's been a very good interaction. We can talk on and on. It's been a bit hard for me to only moderate this panel discussion without going into my cardinal role as the chairman of the Health Committee. But I'm sure you'll invite me for another opportunity to talk about the healthcare system. I thank you very much. Thank you, Ruth. Thank you, Emmanuel, Mrs. Nachivuka, and Rita. It has been a wonderful panel discussion. Thank you.
Thank you so much. Ladies and gentlemen, let's clap for our panel once again as they're taking back their seats. Thank you so much. You may take back your seats in the interest of time. I want to appreciate you who are just joining us right now. We understand that we're already live on NBS television. Thank you so much. Those joining in from home and across the globe, remember the hashtag is UCHD 2023. And the other hashtag is Health Conference. Please and please send us your tweets and be a part of this conversation. Please note that from the UNDP, the country rep should have been with us here, but we understand that she is handling an emergency, but she sent us a representative who is already here with us. Professor Ben Tinomjisha is here with us and will be speaking to us a little later. Without any further ado, allow me right now to welcome Dr. Byachika Sarah, Commissioner Planning and Policy and Financing from the Ministry of Health. She's going to speak to us about the state of Uganda's healthcare services and the priorities for realizing universal health coverage. Please note, this conversation comes as we have the bill of public health on the floor of Parliament, and a couple of those that were passed, 15,000 Ugandan shillings each, if you're to cover this. Let's welcome Dr. Byachika Sarah to talk to us about this. Production, we ready? Please.
Thank you very much, and I think it's still morning. A good morning to you all. It's not easy to give an overview of status of the health sector in just 15 minutes, but I'll try to highlight the key issues. And my presentation will be largely an overview of the legal framework, the health service delivery structure, health status, and then what are the priorities. Next slide, priorities for UHC in Uganda. Where do I point? But where is the, just here. So for the legal framework in Uganda, we are largely guided by the Constitution of 1995, which provides for all people in Uganda to have access to health services, including clean and safe water, education, among other things. We also have a key or major law, that is the Public Health Act of 2000, which was amended of recent to cater for the emerging issues like the pandemics and other developments in health. And the other key legal framework that guides us is the Local Government Act of 1997, which provides for the different roles of the ministries as well as the local governments in health service delivery. We have other laws also that, sorry, what has happened? Okay. Please help with the technology. We have other laws that also help us in terms of regulation in the sector, and more importantly, the last two, the latest are the Indigenous and Complementary Medicines Act of 2019 and the Human and Organ Transplant Act of 2023. We are yet to develop the regulations to have these laws implemented. We also have the regional and international frameworks or agreements that guide us, including the Sustainable Development Goals and more so SDG 3, which is looking at health for and well-being for all, and that is translating into what we are now talking about as universal health coverage. And for us, the key driver of fulcrum for us to achieve universal health coverage is the primary health care, as well as other related interventions. In Uganda, we have strategic documents that provide a foundation for health service delivery, as well as universal health coverage. And these include our Vision 2040, the National Development Plan 3, our National Health Policy, NRM Manifesto. We have a UHC roadmap as well as a Ministry of Health strategic plan. I'll give a few insights into the National Health Policy that is yet to be launched, and the goal is to ensure access to adequate and quality health promotion, preventive, palliative, and rehabilitative services in Uganda so that we can achieve universal health coverage of 90% by 2030. The major shifts in this national health policy is largely to move away from focusing on the 6 WHO health system strengthening blocks and embrace another aspects or expanding to community health aspects involving households in production of health, addressing the social determinants of health, strengthening partnerships with community organizations and other societal partnerships. So the 4 strategic shifts that we are working on beginning 2020 are shifting from predominantly disease-oriented system to a health-promoting system, from siloed and segmented sector-specific interventions to multi-sectoral collaboration with intersection and synergies, from predominantly facility-based care to primary health care and population management, as well as from fragmented and episodic health care to an integrated mode of health care that continues over time. Our service delivery structure, or the landscape for health, is not only about Ministry of Health, but it involves all actors, right from Cabinet or the President, Parliament, which is represented here, other related ministries like education and others. We have development partners, we have the private sector, which is not for profit as well as for profit, including the manufacturers, that is for pharmaceutical, diagnostics, and other aspects, and insurance providers. But also the health consumers form a big foundation in terms of health service delivery. Our structure is organized using that pyramid. As you can see, the lower base is the households or communities which form the foundation up to the tertiary or quaternary level. The peak of this pyramid has shifted from just the national referral hospitals, which were termed as tertiary level, to now specialized, national specialized services, and that is the quaternary level. And this is to address really the population needs. As you have seen, in most times people who need super specialized care have to travel out of the country and we lose revenue. So our focus is also to expand from primary care but also to quaternary care so that we can address the population needs. I talked about the roles by the Local Government Act. The Ministry of Health's mandate is largely to initiate policy formulation, coordination, overall health sector health sector activities, and bringing together stakeholders at all levels to deliver service delivery. And we have those 9 key outputs ranging from governance, infrastructure development, disease surveillance, research, supervision, setting standards and regulations. But when it comes to actual health service delivery, the 1995 Constitution and 1997 Local Government Act provides or gives the mandate of planning for health service delivery, delivering of quality health services, recruitment, resource mobilization, passing of specific bylaws, supervision, and also governance and leadership at local government level. That is the responsibility of local governments. As ministry, we support the local governments, but when it comes to actual delivery, especially of primary health care services, planning, ensuring staff are in place, that is the responsibility of local governments. A quick look at the facilities by level. We have increased from 6,938 health facilities, including public and private, in the country in 2018 to 7,845 as of 2022. Actually, that is not 2020, but that is the year is 2022. And we can see that the majority of facilities are at the lower level in terms of health center 2s and clinics, private clinics, as well as 3s. In terms of ownership, we find that government owns about 43.5% of all the facilities, followed by the private health providers with 43.1%. But it's worth noting that the majority of these, the 2,982 of the private health providers, are actually clinics. As you can see, every corner, if you move in Kampala now, it is now a business setting up clinics. People's houses are now being turned into clinics. So the majority of those are actually private health providers' clinics. That was a quick outlook. So where are we standing in terms of health status? The health status is measured by 3 key areas or outcomes in the NDP3 framework in terms of life expectancy, reduced mortality, as well as reduced fertility. We are very glad that about 2 weeks ago, the demographic health survey results were released, and I'll be sharing the outputs. We are awaiting the census to provide us data in respect to life expectancy. So we are still referring to the life expectancy as of the 2014 census, which was 63, but our expectation is that this should have increased based on our performance in the demographic health survey. I think I don't have to dwell so much on this. You can all see on the streets that our fertility rate is still high, and demographic health survey showed that there was just a very slight reduction from 5.4 to 5.2%. So the issue is, this is a major issue, a public health issue, population growth. However much we invest, if we don't look at population growth, then we'll be diluting all the efforts. And unfortunately, the map is looking funny. I don't know whether you'll be able to tilt your heads, but fertility rate is highest in Karamoja and Bunyoro region. The next slide, I don't know what has happened when the slides went to that laptop, they changed. But Karamoja and Bunyoro, highest fertility. We looked at the percentage of adolescents who are mothers or pregnant with their first child. This has stagnated at about 24% of all adolescents, so it is all still a challenge. That was a slight reduction from 25% in the previous UDHS. Technology is frozen. My next slide was talking about percentage of Women 1549 who are currently using a modern contraceptive method increased slightly from 35% to 37%. So we still have issues of fertility that need to be addressed. Then in terms of child mortality, this is a beautiful slide, but it is now looking funny, but you can read it from bottom up. So under 5 mortality has reduced from 151 per 1,000 live births in 2000 to 52. Infant mortality rate from 88 to now we are at about 36. And neonatal mortality rate from 33 to 22%, although there, as you can see, the reduction is really a bit slow that we need to address. Currently, actually, according to our statistics, neonatal death is the highest cause of death in Uganda. We get more neonatal deaths than deaths to any other condition, including malaria. So we need to address that. Infant mortality rate by region, we can see much as Karamoja has the highest fertility rate, it has the lowest infant mortality rate. Highest is in West Nile region. And we go to under 5 mortality, still West Nile region has a problem. Our chair has moved out, but he told me the LC5 chairperson of Koboko is here. So West Nile region, we need to address that issue of under 5 mortality, which is quite high. And also some regions in the center, you can see there Bunyoro, Uganda, and Kole, under 5 mortality.
of the World Health Organization. The Constitution clearly states the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic or social condition. The right to health for all people means that everyone should have access to health services that they need, when and where they need them, without suffering financial hardship. Suffice it to mean that no one should get sick and die just because they are poor or because they cannot access the health services that they need. With health being a fundamental human right, there is a legal obligation for countries to ensure that access to health care is ensured and that it is timely, it is acceptable, and it is also affordable. A rights-based approach to health mandates that health policies and activities prioritize the needs of the most vulnerable people first in order to achieve greater justice, a premise that is mirrored by the 2030 Agenda for the Sustainable Development Goals and also by the universal health coverage. The right to health is one of a series of globally agreed upon human rights criteria that are inseparable from the other rights. This means that achieving the right to health is both important and contingent to achieving the rights to food, shelter, work, education, information, and also participation. As with other rights, the right to health comprises both freedoms and entitlements. What are entitlements? So this is the right to regulate one's own health and body, for example, sexual and reproductive health rights, and to be free from interference. And this is example, freedom from torture, from non-consensual medical treatment and experimentation. These are actually examples of freedoms. And entitlements include the right to a healthcare system that provides everyone with an equal opportunity to achieve the best possible level of health. Ladies and gentlemen, according to the Article 12 of the Covenant on Economic, Social, and Cultural Rights, there are 4 components of the right to health. And these are: 1, availability; the second one is accessibility; the third one is affordability; and the fourth one is quality. I want to highlight on these ones, but just to raise that the panel session that we just had, if you can all reflect and remember, they have highlighted all these 4 components. And these have come out practically through the different speakers. And I want to believe that we picked all these components. And through that, we have also been able to reflect on what is the situation, what can be done differently, which areas do we need to keep on working on. So I will give a highlight, but as I give this highlight, also reflect on what we just heard from the panel. So availability, this means that we have a functioning public health and healthcare facilities, goods and services, as well as programs which are available and they are in sufficient quantity. Availability can be quantified using disaggregated data for distinct and multiple stratifiers such as age, gender, location, socioeconomic status, as well as qualitative questionnaires to comprehend the disparities in coverage and health workforce coverage. And I think we saw availability through one of the speakers, not being able to hear, for example. The service is available, but it becomes difficult to get this particular service. So for accessibility, Everyone, especially the most vulnerable, must have access to healthcare facilities, goods and services in order to ensure that no one is left behind. Determining accessibility may necessitate to look at which are the barriers that are there. Could it be physical? Could it be financial? And how may it affect the most vulnerable? This informs the establishment or application of clear norms and standards in both law and policy to address these barriers, as well as effective systems for tracking the health-related information and whether this information is reaching all populations. The other component is quality. This is a key component of universal health coverage, and it actually includes experience as well as the perception of health. So, and perception is from the client's perspective. So quality health services, they should be safe, they should be effective, they should be self-centered, timely, equitable, integrated, and efficient. The element of quality in particular calls for ensuring that goods and services must also be scientifically and medically appropriate. Ladies and gentlemen, WHO is committed to the realization of the right to health. From inception, we have remained committed to supporting member states in their efforts to mainstream human rights into policies and programs of health and also in other sectors. As had been highlighted earlier, I think by the Director of Medical Services during his remarks, that when we look at health, a multi-sectoral approach is key. Different sectors plays a key role, and that is why looking at health in all policies is very important. We achieve this by ensuring that the underlying determinants of health are identified and they are mainstreamed as part of a comprehensive approach to ensuring health and human rights. Instances are abound, but for the sake of time, we'll highlight two instances. For example, in 1977, the first WHO expert committee meeting on the selection of essential drugs came up with the essential drugs concept. And this gave rise to reorientation of the role of medicines in public health practice. This gave rise to a model list of about 200 essential drugs needed for the health care of the majority of the population being drawn. The model lists of essential medicines are updated every 2 years with the objective of responding to the ever-changing context and ensuring that the public have access to quality medicines. In May 2002, the 55th World Health Assembly adopted a resolution that urged member states to pay closest possible attention to the problem of patient safety and to establish and strengthen evidence-based systems necessary for improving patient safety and the quality of care. The ongoing campaigns and actions at various levels are promoting the safety of patients and communities using a multi-sectoral approach. WHO's guidance on the realization of the right to health hinges on the need to achieve universal health coverage, which aims at ensuring that all individuals and communities receive safe and quality health services without financial hardship. Universal health coverage must be achieved if the world is to stay on track towards achieving the United Nations Sustainable Development Goals. Ladies and gentlemen, as I conclude, I want to highlight that diversity is an asset, not a threat. When I look around the room, I see diversity in terms of age, in terms of gender, in terms of what we do in our different organizations. all these are an asset that we have. So we must therefore appreciate the richness of our differences, while never losing sight of our common goal on humanity and dignity. So that unifies us, that brings us together, so we have to bring all these assets we have together towards this common goal. Every community, including minorities and also indigenous peoples, must feel that its identity is respected and that it can fully participate in the society. Every individual is entitled to enjoy human rights without discrimination on any basis. We must also recognize that age, gender, and diversity shape the experiences and must be considered in our responses and in our programs. Otherwise, it becomes difficult to realize the goals and targets that we set to achieve. Considering this, WHO strongly believes that addressing the needs and rights of individuals at different stages across the life course requires taking a comprehensive approach within the broader context of promoting human rights, gender, equality, and also equity. Thank you.
Thank you so much. That is the global perspective of this conversation. Ladies and gentlemen, it's noon, and I want to thank you for being very patient with us. The next keynote address is going to come from one of the senior researchers at Afayanaki, Dr. Mutum. Well, and the former Dean of School of Law at Makerere University. He's the first Doctor of Laws and a degree of Makerere University. He has previously worked with the Ministry of Lands as a lands officer, National College of Business Studies as a lecturer, as well as a practical lawyer with Sam and Cotace and Company Advocates. Friends, as he will be delivering the keynote address on behalf of the UNDP country representative who could not make it, I want you to bear with me that as and when our chief guest walks in, we shall pause in the presentation, we shall welcome our chief guest, and then we shall proceed. Ladies and gentlemen, together with me, let's welcome Professor Ben Twinomugisha to come and talk to us about the right to health, a vital component in achieving the SDGs by 2030. Let's welcome him until when he gets here. This is a prof.
You're welcome, sir. Andrew, thank you. Thank you very much, Andrew. I don't know, Andrew, what I would... So when the minister enters, you don't have to remind me, I'm not used to these things. When the minister enters, I go this side. Don't tell me, because I don't want to make mistakes. I pause, I remain here. It's okay. And I bow. No, I'm sorry, I'm not used to these things really. I don't want to make errors that may be costly. Ladies and gentlemen, yes, I'm Ben Twinomugisha. I'm a professor of law at the School of Law, Makerere University, where I have taught since 1986, and those other places he has been talking about at the diploma level. This speech is supposed to be delivered by LCG Atafwa, the resident representative of the United Nations Development Program in Uganda. So when I talk, those who know her, you imagine how she talks. Yes, I have my own views about realization of right health. Maybe I can even say them before the minister comes. to me, it's not a matter of lack of resources that this government, like many other African governments, cannot realize the right health, including meeting a substantial portion towards the 15% target agreed upon by ministers in Abuja. To me, it's a question of prioritization. It's a question of tackling corruption, that is the hemorrhage of resources that would have met the social economic service such as health. It is a question of the bloated administration in terms of a huge parliament, a huge cabinet, a huge many RDCs, many special resident district advisors, at times unjustified classified military and other security expenditure. And in other words, if we can prioritize our resources and marshal them, focus them towards realization of this right, including, for example, substantial investment in human resources for health, whereby we may manage the brain drain among our doctors who are training in the various places, and many other issues, including also ensuring that the state comes back to invest heavily in health, not leaving it largely to the private providers, according to the dictates of the neoliberalism spearheaded by World Bank and IMF structured adjustment programs, where health care is left only to the market largely through commodification of health care, where we saw, for example, in COVID, people failing to meet health care. I can talk about the political economy of health until dawn, but let me go here. Okay? So I have my other views. So what I read here is what I was given to present. Yes, because there are many other things which are not here, including implications of, for example, the Anti-Homosexuality Act on realization of health rights, where people are going to be driven underground without accessing health care, criminalization of transmission and attempted transmission of HIV, whereby persons living with HIV are going to be denied or are going to fear to test, which is an entry point for care, support, and treatment. So there are so many things. But that is now, you see two places, Ben, who has just talked, and Ben, who is going to read this, okay? Yeah. Honorable Minister of Health, Dr. Acheng Jane Ruth Ochero, the World Health Organization country representative in Uganda, honorable members of Parliament, officials from the Ministry of Health and other government ministries, departments, and agencies, UN agencies present, the SAHAD trustees and